We have some exciting news to tell you about today regarding hepatitis C. There are new drugs available called direct-acting antiviral agents, or DAAs, which are associated with very few side effects and have success rates of over 90% in clearing the virus. Hepatitis C is a major player of cirrhosis, is our #1 cause of liver transplants in Alabama and the United States. Hopefully, with these new agents, we're able to clear the hepatitis C virus and prevent patients from developing cirrhosis, hepatocellular carcinoma or liver cancer, or need a liver transplant. This slide shows the hepatitis C virus. The virus is a very small virus and is able to mutate. Fortunately, with new direct-acting antiviral agents, these drugs are capable of binding to various proteins seen on this slide. There are proteins that can bind to the NS3, NS4A, NS5A, and NS5B proteins. By binding to these proteins, the virus will be prevented from replicating. These direct-acting antiviral agents are successful in blocking the virus from replicating. With treatments of anywhere from 6, 12, sometimes as much as 24 weeks, we are able to block the virus completely and clear it from the body. By clearing from the body, the person can be cured of his hepatitis C. This slide shows the progression of hepatitis C treatment since 1991. I started treating patients with hepatitis C in the early 1990s. Success rate at that time was under 10%. However, with the new direct-acting antiviral agents, we are successful in over 90% of patients in clearing virus. These patients are considered cured. With new agents, these agents do not require interferon and do not require ribavirin. Both interferon and ribavirin had significant side effects that really prevented most patients from being treated. However, with the new direct-acting antiviral agents, discontinuation rate is 1%. This slide shows the estimated progression of hepatitis C with decompensated cirrhosis and the development of hepatocellular carcinoma. Decompensated cirrhosis are patients who develop ascites, or fluid in the abdomen, hepatic encephalopathy or confusion, jaundice, variceal bleeding, or hepatocellular carcinoma. It is estimated by 2025 we will have over 140,000 patients with decompensated cirrhosis. In addition, at the same time period, approximately 18,000 patients will develop hepatocellular carcinoma. Unfortunately, there is only about 6,200 liver transplants available each year in the United States. If you just look at the patients with hepatitis C, we do not have enough livers to transplant these patients. It is hoped with the new direct-acting antiviral agents, we are able to decrease these peaks and hopefully prevent all these patients from developing decompensated cirrhosis, and hepatocellular carcinoma. Omar Masood, one of our liver doctors here at UAB, who has been treating many patients with the new direct-acting antiviral agents, will now talk about the epidemiology of hepatitis C.
Hepatitis C is a major health problem all over the world. In the United States, the prevalence of hepatitis C is 1.8%. That's about 4 million individuals. It's the principal cause of death from liver disease. It's also the leading cause for liver transplantation. Although hepatitis C is curable disease, unfortunately, it's underdiagnosed and undertreated. It's estimated that 3/4 of individuals with hepatitis C are unaware that they have infection. Not only that, but even people who are aware that they are infected, most of them actually never receive treatment. This is a big problem, and to be able to solve it, we have to know where it came from. In 1998, the Center for Disease Control and Prevention issued a recommendation for testing people with hepatitis C. Later, the American Association for Study of Liver Disease adopted this recommendation. And what this recommendation basically says is that primary care physician should ask their patients about any hepatitis C risk factor. And whoever reported one or more risk factor should be tested for hepatitis C. There is a long list of risk factors for hepatitis C. The most important of them are IV drug use and blood transfusion prior to 1992. Now, after 10 years of implementing this recommendation, we realized that they are suboptimal and they are not doing what they were supposed to do, which is basically diagnosing people with hepatitis C. And we tried to find out why these recommendations are not working. And we found several reasons. Number one, primary care physicians are too busy. They cannot ask every single individual about all this risk factor. Number two, many patients do not feel comfortable in discussing topics like IV drug use with their physician. In fact, many physicians even do not feel comfortable in discussing these topics with their patients. As a result, this recommendation were not followed and were not working. And again, most patients with hepatitis C remain undiagnosed. The results of a large survey published in 2006 showed that 70% of hepatitis C patients were born between 1945 and 1964. In addition, people born between 1944 and 1965 have 4 times the chance of having hepatitis C as people born outside this time frame. Now, if this is the case, this means that if we tested everybody born between 1945 and 1965, we will be able to capture 70% of people with hepatitis C. And this was the idea of BEST-C study. BEST-C, or Birth-cohort evaluation to advance screening and testing for hepatitis C, is a large multi-center study sponsored by the CDC, started in 2010. The UEB participated in this study. This study showed that testing people based on the year of birth would increase the rate of diagnosing hepatitis C 5-fold. In fact, the result of this study led the CDC to change the recommendation. Now, the new recommendation for testing people for hepatitis C indicate that any individual who was born between 1945 and 1965 should receive one-time testing for hepatitis C.
Mohammed Shareba, another liver doctor here at UAB, has been treating a lot of patients with compensated and decompensated cirrhosis, trying to clear their hepatitis C before they need liver transplantation. He will now talk about many of the complications seen in patients with hepatitis C.
We will discuss the complications of hepatitis C infection. So this is a worldwide epidemic. It affects 3 to 4 million patients in the United States, and probably more than half of those patients do not know that they have hepatitis C infection. The disease can invite chronic inflammation in the liver and progressive formation of scar tissue. If that scar tissue buildup continues, then that's what you call cirrhosis of the liver. And cirrhosis is associated with lots of complications, including the potential for development of liver cancer. Unfortunately, we see that in about 5% of the patients that have hepatitis C with cirrhosis per year. And our preventive measure for that is to enroll our patients in screening and surveillance to make sure that we detect those tumors and treat them early on. Another complication that could happen as a sequela of cirrhosis of the liver is the development of portal hypertension, which could lead to bleeding from the stomach and the esophagus, the food pipe. And this is what we call esophageal or gastric variceal bleeding. And our preventive measures to take care of that would be to place the patient on certain medications, namely beta blockers, and those tend to lower the portal pressure and prevent that dreadful complication. We can sometimes resort to an intervention called band ligation to prevent bleeding from those varices as well. Another complication is the accumulation of a toxin called ammonia that's supposed to be filtered in the liver circulation. And when the liver functions are not working properly, then that toxin will build up and would affect the neurotransmission in the brain, leading to quite a bit of confusion, disruption in the sleep cycle, and the patients may also experience balance problems, falls, and injuries, and they can even progress to coma. We use certain medications to clear the ammonia from the body and try our best to prevent that complication as well. Another thing is progression of the disease itself, leading eventually to what you call end-stage liver failure. And at that point, you would evaluate the patient for a liver transplant. And being in a specialized tertiary care facility here, we do about 100 liver transplants per year, and hepatitis C causing cirrhosis of the liver ranks as #1 cause for the need for liver transplant in our facility and nationwide. Fluid retention is a problem that we encounter quite frequently in cirrhosis of the liver secondary to hepatitis C infection or other causes. And what happens is a faulty signal in the body that leads to release of certain hormones that makes the patient retain the salt and subsequently the water. And that could manifest by swelling in the lower extremities. It can also lead to accumulation of the fluid in the pleural cavity around the lung and in the abdominal cavity in the belly. And we have measures to try to treat that problem or alleviate it at least, including the restriction of the salt intake for the patient with cirrhosis of the liver, and we usually restrict our patients to 2,000 milligrams per day or less. We also use diuretics to help get rid of the excess fluid overload that the patient has, and sometimes we do interventions to drain the fluid around the lung or in the abdominal cavity. There are other more invasive measures to alleviate the volume overload, including the placement of certain metallic shunts inside the liver to try to drain the blood properly and overcome the portal hypertension that develops with cirrhosis. The ultimate treatment for all the problems and complications that develop from cirrhosis of the liver would be, of course, doing a liver transplant, which could alleviate the portal hypertension, the confusion from the ammonia, prevent the risk of development of liver cancer as well. The prevention of complications of hepatitis C and the development of cirrhosis would be depending on two main aspects of treatment. The first one is the treatment of the virus itself. And we have quite a bit of a revolution now in the treatment of hepatitis C with the development of new regimens that do not require the use of interferon. Interferon is our traditional medicine that's been used for many years and currently used also in some regimens for treatment of hepatitis C with a whole variety of side effects. So we're very enthusiastic about treating patients now, and we anticipate more breakthrough medications to come before the end of this year. The second aspect in overcoming this problem and prevention of complications of hepatitis C would be basically prevention of a second hit to the liver. we find in our patients with chronic hepatitis C that the presence of what you call metabolic syndrome, which is basically obesity, diabetes, high blood pressure, and disruption of the lipid profile of the patient would accelerate the damage and the inflammation process and definitely lead to more complications and at times even lower the response to the hepatitis C treatment. The other hits also that can affect the liver, of course, alcohol consumption. So we advise our patients to avoid alcohol consumption because you would get accelerated damage when you use alcohol in the presence of hepatitis C infection. So it's basically trying to prevent what you would call the second hit theory, any other offender that could inflame the liver first and accelerate the damage process. The question that we get quite frequently is cirrhosis a reversible process? So as we mentioned in the beginning, cirrhosis is accumulation of scar tissue in the liver, leading to stiffness and deterioration in the synthetic functions of the liver. The liver is a factory, and if it has a lot of scar tissue sort of dominating its normal cells, then that can impact its synthetic abilities and lead to eventually liver failure. Well, interestingly, treatment of offending factors that led to the development of the scar tissue can definitely help the liver regenerate better and lead to regression in the scar tissue. We still would like to bring our patients' attention that once you're diagnosed with cirrhosis, even if we're able to treat your hepatitis C or you eliminated the cause of your cirrhosis other than hepatitis C virus, then the standard of care is that you would still be enrolled in a process of preventive care. We still want to screen for cancers. We still want to do endoscopies to make sure that you don't have varices. But what we can say is definitely the regeneration process happens better when you treat the hepatitis C, and there would be some regression in the scar tissue that was already formed.
Stephen Gray, one of our 4 liver transplant surgeons here at UAB, will discuss the interactions of hepatitis C with respect to liver transplantation.
The number one indication of liver transplantation is hepatitis C, and over the next 20 years, that proportion is projected to increase. Patients with hepatitis C do not get cured with a liver transplant. They are cured from their liver disease, but the hepatitis C will recur in the new organ immediately. Patients who have been transplanted for hepatitis C have approximately 10% lower survival rate at 5 years as compared to patients who were transplanted for other causes. Patients can be treated for hepatitis C both before and after liver transplant. The purpose of treating them is to eradicate the disease and increase their survival.
Mike Sag, infectious disease doctor here at UAB, will discuss current and future roles of hepatitis C therapies. He's been very active in this aspect and has had done research treating patients with these new agents.
The progress in hepatitis C has really been breathtaking. When you think that a virus was just discovered in 1989, new therapies in the form of interferon in 1990, and then long-acting versions of interferon with the pegylation once-weekly injection in the mid to late 1990s, leading to about a 30-40% cure rate. That was good success. But in the last 4 to 5 years, there's been an explosion of new drugs, these so-called direct-acting agents, which when used together, even without interferon, even without ribavirin, getting cure rates of 95 to 100% is just striking. And that's where we are right now. From the summer of 2014 forward, we won't be using interferon anymore. We won't be using ribavirin much anymore. And I predict by this time next year, in the summer of 2015, we won't be using ribavirin at all. So there are a lot of ways to determine whether the virologic therapy has been successful. At the end of therapy, after the 12 weeks of, say, 2 or 3 direct-acting agents, you'd like to see the viral load totally undetectable, but that doesn't tell you whether or not you've had success. You want to follow the patient for a period of at least 12 weeks. after the end of therapy, and that sustained period, that sustained success, is called a sustained virologic response, or an SVR. Once someone has gotten to an SVR 12, or 12 weeks after the end of therapy, that is considered to be cured. So in other words, if you have a patient who has had success at the end of therapy with undetectable virus, and that undetectability is sustained for 12 weeks after the therapy has been stopped, that sustained virologic response is tantamount to cure. That means the virus is gone and won't come back again unless the patient gets reinfected. There are a fair number of patients, about 20% nationally in the United States, who have HIV and also have hepatitis C. Those are so-called HIV-HCV co-infected patients. Traditionally, with interferon-based regimens, their response rates were not quite as good as those who just had HCV alone. With the new direct-acting agents that are now available in 2014 and even more to come in 2015 and 2016, when those drugs are used together, there's really no difference in response at all between those people who are HCV mono-infected, that is without HIV co-infection, and those who have HIV-HCV co-infection. So the patients with HIV who have hepatitis C are getting cure rates of 95+% with the direct-acting agents without interferon, without ribavirin. So it's a really exciting time. The one caveat of treating people with HIV-HCV co-infection is that we have to look very closely for drug-drug interactions, because some of the newer agents are very similar to HIV drugs, and there can be a lot of interaction between them. So the providers need to be aware of those potential drug-drug interactions, look them up, and modify the antiretroviral regimen that the patient is on, or modify which HCV therapy is used. But it's very manageable. Anyone with hepatitis C is going to be better off without hepatitis C. Curing them is a good thing. And there are certain patient populations who are going to be more difficult to treat because of either their underlying condition, that is, they got very advanced cirrhosis and end-stage liver disease, or they might have an underlying condition that requires very aggressive immunosuppressive therapy, like a bad rheumatologic problem, or perhaps a person who's had a bone marrow transplant. Those individuals are going to be more difficult to treat, but not impossible. And so I think over time, everyone with hepatitis C will be treated and cured of their hepatitis C with the new drug therapies. It's just that those patients who have had a transplant, be it bone marrow or even liver transplant, those people with advanced cirrhosis, those individuals are going to be a little bit more difficult to treat, just because you're looking at drug-drug interactions between the immunosuppressive drugs that are being used to keep the body from rejecting the organ that in a transplant situation, or they're on other medicines that don't get along well with the direct-acting agents that we'll be using. But overall, I think most everyone will be able to be treated successfully for hepatitis C. In my career in medicine, and that mostly includes HIV, where we've converted HIV from a certain death sentence to a chronic manageable condition, I've never seen anything like the revolution in hepatitis C therapy as we've seen in the last 2 years. So over the next couple of years, that revolution is just going to continue. There'll be more drugs, better drugs, once daily drugs, combinations that will probably take the length of therapy for cure from 12 weeks to perhaps 8 weeks, 6 weeks, maybe even 4 weeks. So we're talking about an incredible ability to get rid of this virus once and for all. And if theoretically we treat everyone who's got hepatitis C and get rid of it, we can actually eradicate hepatitis C from the world. Big picture, hard to do, because you got to find everyone who's got it and treat them and cure them. But if we're able to do that, it could be like smallpox. It could just go away. And that would be a very exciting time, maybe 20 years from now.
In closing, we hope you have enjoyed this conversation with hepatitis C. We think it's a very exciting time for treating our patients. Hopefully, with your help, hepatitis C can be cleared in the next 10 years. Thank you very much.